I'm super excited about our episode today. We're talking about cupping, the evidence and application to clinical practice as well as sports. I'm excited to be joined by Dr. Chris DaPrato, who's spent a good portion of his career studying fascia, myofascial decompression, which we all kind of know as cupping. He calls it cupping with movement and load. Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, I'm an author at philplisky.com, founder of Coaches Club, and a performance systems consultant in professional sports. Being a physical therapist, an athletic trainer, and strength and conditioning coach, I like to come at this from multiple different perspectives. But we want this to be evidence-based. We want the latest research, but we also want it to be practical for you. Welcome to the podcast, Chris.
Thanks for having me, Phil, and thank you, MedBridge. This has been a great experience so far, putting our courses and updated science up on the MedBridge platform. We're excited to talk about it.
Fantastic. Can you get us started by just giving us a little bit of background about yourself so we kind of know where you're coming from?
Definitely. So I've been a PT for about 20 years, and I started out as a personal trainer, strength conditioning specialist. So I got my CSS way back when. And going through grad school, I was doing personal training on the side and some sports performance aspects. Got out of there, did the typical private practice, saw way too many patients in a small amount of time and learned a lot. And then eventually went on to appreciate how manual therapy could also be combined with exercise prescription to make a really winning combination. And those skills really developed into getting into a position with Cal Athletics at Berkeley. So in the Division I training room, I was probably there 4 days a week working with Division I athletes in like 2008, 2009. And manual therapy was a really laborious endeavor when it comes to working on football players, rugby players, soccer players. So I really tried to find more efficient ways of using manual therapy, again, pairing it with strength conditioning and some of the other things I used with NASM modeling. And I found that instrument-assisted tools were great. And then I got introduced to cupping. And the cupping stuff was really a different type of modality. And there was really an absence of literature and research in this area as it relates back to sports performance or orthopedics and things. So I started scouring the literature and finding almost nothing. And then started finding how these outcomes were really improving, even compared to things like Graston or instrument-assisted soft tissue mobilization. So I wondered, why was this helping so much? So I went on, got my board certification in sports physical therapy, did some more research aspects, and I got onto faculty with UCSF, which is a DPT program here in San Francisco. And I was on faculty there for about 7 years. And we really started diving into the science and the evidence of fascia and some of the evolution of fascia that's out there. And we'll talk a lot about some of those aspects and some of the misconceptions in there. And still found that cupping was being widely used as a passive modality. And we were really promoting it at the time to be more of a active modality, something you put on someone while they're doing their first set of a deadlift or their first set of a squat or their first set of a leg press to, again, decrease pain, decrease fear avoidance, try to empower the client to get load on there faster. And we found it to be really effective, but we had to differentiate, I think, a little bit of what cupping was traditionally. And we'll talk about traditional cupping as compared to what we came up with this idea of movement and load with cups, which we termed myofascial decompression. So we've been studying that and doing more research for the last, 5-10 years now. And I'm excited to share some of that with you guys.
Oh, that's fantastic. So, all right, let's go right after it. I mean, this is a topic that, boy, it's kind of a hard one to explore a little bit. I mean, there's some topics like, doing eccentrics with, tendinopathies and things like that we can, go on a good amount of science. This one is a little bit different that way. So, but it has some evidence behind it. Can you talk about why you think this is important as an active modality? What's the big deal behind this?
Absolutely. So one of the things I love is that fascia is hot in the news headlines in terms of collagen supplementation, in terms of a lot of tendinopathy management. The idea of fascia is very both hot, but also polarizing. And when you think about manual therapy and fascia, people are like, whoa, that you can't change collagen cross bonding. You can't change fascia with manual therapy forces. And for the most part, they're right when they're talking about big, strong, thick IT bands or other things that we think of as, durable collagen that produces a lot of force or transmits a lot of force from the muscles to generate myofascial force transmission. And so we think of fascia as like this connective tissue piece, but fascia is everywhere, right? It's our ligaments, it's our cartilage, it's our connective tissue that links it all together. And you really got to be a little bit more specific about what area of the body you're talking about specifically, because it's all a different kind of ratio of collagen to ground substance, to elastin, these different, it's like a Jell-O that has a different recipe depending on what part of the body it's in, right? So when we think about breaking apart, collagen cross bonding with manual therapy, absolutely, that's poorly, I think, discussed in the literature. We don't have great literature. We don't even know what we're doing when we think about trying to disturb the collagen matrix. Some of that research is slowly emerging. And when it comes to cupping, it's even more of a vacuum, because what do we know about
vacuum, so to speak?
Yeah, exactly. The vacuum on the vacuum. So just the way we have to uncover and go back to like some of this bench foundation science and some of the literature that is out there on collagen, on fascia, that we can kind of uncover with some of that. So that's really kind of the interesting part about differentiating, I think, fascia from a manual therapy standpoint and then fascia from an exercise standpoint and a loading standpoint. And they have the same foundations, like your signaling in your body is going to respond to load, whether load is a dumbbell, a band, your own body weight, or actually the forces generated by a cup being on the body. That is still load. And you are going to have some excitation of the fibroblast to lay down new collagen and organize collagen in a different kind of way. So we have to go back to kind of some of that basic foundational science on collagen production from the fibroblast, and then talk a little bit about what this other cell is called the fasciocyte, which lays down the lubrication for the tissues to glide and slide past each other, which is what I think people are trying to refer to when we think about manual therapy. Is we're not going to break up that collagen stuff. We're exciting the lubrication and improving the glide surfaces as a temporary improvement in those tissue qualities.
So beyond even a basic science, so, what is happening at a basic science level? What does the research tell us that? And then does that translate into, actually, randomized controlled trials and things like that? Let's head down that road.
Absolutely. So let's just start with where we're at now, which is still kind of limited when it comes to randomized control trials, especially double-blind, well-designed studies on pairing cupping with another modality and comparing the outcomes of the two compared to a control maybe of no intervention whatsoever. And where we're at now is there are few studies that improve the range of motion of a particular demographic of clients, because when you put a cup on the body and you don't introduce motion in that methodology, you're not going to improve the range of motion. And most of the cupping literature from, I'd say, 2019 and before was all passive cupping, which is a different animal entirely compared to something like myofascial decompression, where you're moving through a range of motion while the cup is on. So when we look at those studies, there are probably only about 3 or 4 actual studies out there that look at methodology that uses range of motion during the actual procedure and the intervention, as compared to most of the passive studies that you will see in the past. And so referring back to those. And so when we think about like the systematic literature review that came out in 2021, they looked at neck pain having some moderate evidence. Back pain have a lot of studies, but very poor methodology, very low quality studies. And then things like neurodynamics for carpal tunnel and knee osteoarthritis. So there's some things out there that have some inkling of some studies that are getting better. And again, we just have to compare apples to apples when we think about, is the literature supporting this modality when we think about mobility changes and improving range of motion. And there's only like 3 or 4 studies right now that does do that well. And they show, good outcomes for the type of intervention with cups plus movement.
That's interesting as you kind of look at that. There's a couple different things to unpack there, because it's a lot about study design, right? It's not only having, because in reality, in clinical practice, we're not going to necessarily just do any one modality or any one treatment or any one technique or any one exercise for that matter, and then say, okay, which is better. So we've got that problem. We've also got the problem of, does the person need it, right? So how do we determine that this person would benefit from cupping? And are we applying, again, if we were studying a blood pressure medicine, we wouldn't give it just to everybody in the population and say, does this blood pressure medicine lower blood pressure? Well, it may or may not. And depending on whether it may be effective, it may not be. We don't even know. And then on top of that, you confound it with, does the person actually need it or not? And is it the only thing that you would do? Can you speak to some of those methodological problems and how we address those?
Yeah, you're nailing it on the head right here. So when we think about things we do in the clinic, and especially when it comes to manual therapy, it's an adjunct. It's a component of the total treatment that you're trying to deliver, with education, with exercise prescription, with, adjusting their volumes and their intensities and what they're going through in terms of progression, regressions. It's a little piece of that pie. And so when we go to study something, especially in manual therapy, we're trying to isolate all of the variables and normalize these variables to isolate a single variable to say, does this help with or without, and blind it and make sure that we're trying to take out as much placebo effect as possible, which is kind of impossible on some of these studies. Again, compared to a pharmaceutical study where it's very easy to blind people and have them not know what they're getting. Well, when you get a cup on your body, you're going to feel it. And often, right, you're going to have a color mark afterwards. And we'll talk about why there's color, why there's not, and whether it matters or not even. And it's going to be very easy for people to see whether they had the treatment done or not. So it's really hard to compare that. And I think even like a dry needling study, you can have sham dry needling because some people won't feel it quite as much as others. And so you can have a treatment effect still and have them blinded to whether they actually got needle penetration or it was just touching the skin, because the skin is the big receptor site for, what we're sensing. And with a cup, you're usually expecting some type of raised mark that is colorful or not colorful afterwards. And it's really hard to, establish that blinding because of that component of it. And then when we think about the study design, when we look especially at the history of the literature on cupping, they're not normalizing for pressure. They're not normalizing for time left on. They're not normalizing for the material that the cup is used. What's the diameter of the cup? A lot of times in the methodology section, you don't have any of those details. So when we're trying to compare one study to another, it could be total apples and oranges again because of the variance of those types of variables that they're looking at.
It's interesting, as long as, companies been around in a lot of different forms for forever, let's say. It's a really long time, certainly hundreds, if not thousands of years, right? And so it's somewhat surprising that there wouldn't be more evidence on it. And, again, the evidence is widespread. Everything, there's a lot of early evidence on wet cupping, and there's actually current evidence on wet cupping where they, actually, pierce the skin and cause bleeding and things like that. Now, there's a lot of studies on that. Why do you think there aren't the studies? I mean, dry needling is emerging in that study area. Why is cupping not hitting it as well as you would think?
I think from a historical standpoint, it was just a holistic tool in their medicine that was just combined with all the other things that they would do. So they would do moxibustion, they would do herbal remedies, they would do needling, they would do a lot of these holistic approaches, and cupping was just thrown in there with it as, again, an adjunct component of it. And it did blow my mind because I was trying to scour the literature. I was in these debates with people that were saying, cupping doesn't pull on anything except for subcutaneous fat. You're not touching the muscle. You're not pulling the muscle at all. And this was like 2013. And these, at the time, Instagram wasn't big. It was more like forum, chats and these blogs and things. And some of the antagonists for manual therapy said, cupping doesn't do anything because you're only pulling fat. And I was like, I'm pretty sure it pulls the muscle because I'm seeing these, effects at the muscle level in terms of like old hamstring strains and scar tissue management for some of my athletes. And they're like, go show me the literature. And I scoured the literature and it didn't exist. And it blew my mind again that there was no imaging that really looked at what depth of penetration a cup was providing. And I was like, this is not good. Like, we need better information here. And so in 2014, 2015, I got thrusted into the research world. I'm a clinician. I love the clinical setting, but nobody was answering the questions that I had. And I needed some of these answers to be a better educator when we talk about why we're doing what we're doing and some of that clinical reasoning. So we started doing imaging for the first time ever in 2015 by putting a live human in the MRI at our research lab at UCSF with a cup on the body. And that was the first time it had ever been done. So we did that in 2015, and we started sharing some of those results and started working with Team USA in 2016. And that's kind of the reason you saw the Michael Phelps effect of 2016, is that we worked with Team USA in 2015 with the gymnastics group, and then 2016 with the Team USA swimming. And that's the big hoopla that kind of was the big stage for all of it to blow up. But I was very shocked at the lack of any type of, mechanical studies looking at what does a cup actually do to the body and how long does that last? And that just didn't exist until we started doing it at UCSF.
Yeah, it is interesting because you follow even a previous podcast with Johnny Owens on BFR, right? There's this it's this, you can watch the evolution of the science. It starts in clinical practice and then gets applied in the studied in research, and it just seems that it's just stayed in clinical practice. So so let's talk about a little bit of those mechanistic studies though, because that is where it starts. It starts with basic science studies as kind of saying, hey, this might be what's going on. Yeah. What do we think's going on based on the research?
Totally. And you're right. Like, the clinic leads the lab. It's not the other way around. The lab doesn't say, here's what's happening, and we're going to take it and apply it to the clinic. No, we start in the clinic usually, just like, blood flow restriction training and things like that. So what we saw was that we need to identify how deep does this actual effect happen? And are there various pressures that will generate a deeper effect? And the diameter of a cup, right? There's very small cups and there's very large cups. And so we really want to nail down some of the parameters of pressures and then durations, and then also looking at how long those effects can last for. So our first study was just looking at, what depth does it get? And so we put a cup on the upper trapezius and we put them in the MRI and we looked to see how deep did it affect. And it blew our minds of how much muscle tissue was being pulled into the volume of the cup. So you had like the layer of your epidermis rising up inside the volume of the cup, along with the deep fascia, along with not just the upper trapezius, but you're actually tethering upwards the supraspinatus under it. So it really blew our mind on how deep a cup can affect. And that was just our first pilot study. And then we wanted to see some more about the pressures. And so we put 2 different humans into the MRI with 4 different scenarios: a silicone cup at 175 millimeters of mercury, a silicone cup with 300 millimeters of mercury, and then a plastic cup with 200 millimeters of mercury and a plastic cup with 500 millimeters of mercury, just to see on the lumbar spine how deep those effects were. And it really blew our minds that the pressure to generate a little bit of tethering of those paravertebral muscles, meaning our erectors of our back, was around 250 to 300 millimeters of mercury. We could pull up some muscle with that amount. Now, if we went up to 500 millimeters of mercury, we actually pulled all the way down to multifidus. And we could actually tether upwards, not into the volume of the cup, but upwards away from the spine, the multifidus. And what we want to do that for is basically to generate better slide glide components. And often the multifidus in the research world of low back pain has fatty infiltration in, right? Mm-hmm. So those segments don't move as much. And because of that lack of motion, you have decreased movement, which stimulates decreased need of muscle. Muscle's a very metabolically costly tissue. And if your back says, well, you're not going to move there anymore, I'm going to take away some of this muscle, I'm going to put in more fat. Well, that's not a good thing for us, right? And they see that often in persons with low back pain, chronic low back pain. So we want to get in there and we want to mobilize some of that tissue and get those tissues to move more and then load them so that you start to get better cross-sectional area of the muscle at that multifidus level. So using a cup there isn't to like take out the demons or take out the toxins or, do the things that traditional cupping was used for. It's to mobilize often. And so as a low-hanging fruit, we try to mobilize that tissue. And so that was a study we were really proud of to say, okay, this is the pressure that you need to get down to that level. And then this is what those effects are, even on something as deep as the multifidus in the lumbar spine. And then our fun one that we really kind of jumped into how long these effects can last for was using it on the IT band. And so using it on the IT band, we had people come in, get an MRI done, and have them come back 3 days later and get another MRI done to see if there's still tissue effects then. And we saw a statistically significant difference in the tissue space between the IT band and the lateral femoral condyle when you look at them after treatment, for sure, but also 3 days later. And so what we're postulating is it probably has about a 5 to 10 day effect window when we think about when we put a cup on the body, how long is that going to last for in terms of improving that slide glide surface of those tissues.
That's awesome. So, if I were to ask you to be kind of to argue the flip side, okay? So you've given us the basic science. We know we've got a few range of motion studies that say, there's some effect there. If I were to ask you to argue the flip side and say, hey, tell me why cupping has no research behind it and is ineffective.
Yeah. So first of all, funding for manual therapy studies is probably the biggest driver of that. There's just not a big funding for that. When you talk about heart studies or cancer studies or, there's big funding, again, relatively big funding that may be drying up now a little bit more so, but there's things that are well-funded and things that aren't. And unfortunately, manual therapy has a low blip on that radar of importance when it comes to NIH funding and some of those things. So if I looked at the research and I said, as a systematic meta-analysis, is cupping helpful? It has, again, really poor methodology in most of the studies. A lot of times these are holistic medicine studies that come from often other countries as well. So you see some studies out of Korea, you see some studies out of the Middle East, you see some studies out of China, and they're not controlling their variables very well. They're often not blinding the participants or the practicing provider that's implementing the intervention. And so you can very easily say and dismiss that cupping really doesn't do very much when you don't think about any of the mechanical components of that. Again, it's because historically this is just a poorly studied intervention. And so as we move forward with better science, with better controlled variables, I think you're going to start to see a lot more of these studies show significance, and then some of the outcomes as it relates both to mobility, but also for tissue remodeling. And one of my favorite ways of thinking about tissue remodeling is going back again to collagen. And if you haven't listened to updates in tendon repair in the last 5 years, there's so much new great stuff when it relates to collagen and tendon repairs and tendinopathy. And some of the things that we saw 10 or 15 years ago from Jill Cook, and these are cool models, but they're getting flipped on their head right now. And some of the ways we think about collagen, we know that loading is important, but we didn't know how effective some of the loading principles are with that. And when we think about a cup on the body, I think moving forward, you have to understand that's a low load early intervention to gain the patient's ability to add load over time. And so that's the way we like to think about using the cups, is both a loading kind of facilitator, but then also body awareness. Like, what's the position? Are we maximizing the position for the loads that we want in that particular area, right? And so we could talk about some of those interventional things as well. But yeah, you're right. On a systematic meta-analysis review, it's pretty poor out there because, again, historically, they don't look at movement and they don't look at controlling variables there.
I looked at one study looking at dorsiflexion range of motion, a topic near and dear to my heart. But it is, it was interesting. And correct me if I'm wrong. I'm sure you know it even better than I do. It was basically that if you applied a sham cup, it didn't do much. If you applied a cup but didn't do anything, no movement on top of it, it may have done a little bit, maybe not. And then, but if you did a cup, cup with movement, we got range of motion improvements. And one of the things that the study kind of concluded was, it seems that the range of motion improvement, it just exceeded the MDC and, is at about 5 degrees. One of the things they concluded was it seems that it's similar to other interventions. They all kind of seem about the same. How does that, how do you put that into your frame of conference? First of all, or frame of reference. First of all, did I get the underlying, meaning of the study? And then B, how do we take that into clinical practice and go, all right, this is what that means?
Yeah, absolutely. I think the value of something like that study and relating it back to other modalities that we use all the time, whether it's foam rolling, whether it's instrument-assisted scraping, there's so many tools under the sun that kind of do the same thing because we're having the most effect on the nervous system, right? And so when we go back to where are these effects happening, there are some mechanical effects, and we can see that from some of the imaging that we've done. We can see that using diagnostic ultrasound and MRIs, but you can also use, the idea that the brain is the most powerful thing that we have in the body when it comes to a manual therapy effect. And so when you see some of those effects, you're going to see that they're going to be very similar across the spectrum of different modalities, depending on the study design on how, effective that's really going to be. And so the power of it really is giving the client the options of what they're looking for, because the biggest predictor of your outcomes is what the client expectations are coming into the clinic anyways. So if you've had a client or an athlete that comes to your training room or your clinic or your, wherever you're at, and they say, I've had cups in the past and it works magic for me, and you don't know how to do it, or you've never used it before because you're like, that's not really great science because the literature doesn't have good meta-analyses on this yet. Well, that's what they wanted coming into there. And so again, it's one of those patient outcome things when they have high expectations for this tool to help them, that's something that you probably want to be able to provide for that. As compared to scraping, maybe they hate scraping, but they've had cups in the past. They're going to have similar outcomes on that neurophysiologic effect. And you have to kind of choose what's going to be the most appropriate for them.
So as we look at that clinical practice component of it, we are seeing, you look at, you mentioned the Michael Phelps effect, and, we frequently will see Instagram posts, and I think you do a lot of them on your channel where, we'll see a dozen cup marks on someone, and, it's almost a badge of honor for both the clinician and the person. Give me your thoughts on that.
Yeah, I mean, these days, the Michael Phelps effect was good and bad. It was good because it removed some of the stigma and this like, oh, that's voodoo science, that's some weird fringe things, into much more mainstream. And I think people took it and ran with it a little excessively. And now my athletes come in, and if they haven't gotten a mark from, using 1 or 2 cups going through motion, they're like, oh man, I didn't get a mark. I'm not going to get the effect. I'm like, no, that's not the point. The point isn't getting the mark. So, part of it's an issue when it comes to, again, this framework of what is in the literature, what is the science starting to say about it as compared to, what a high school athlete that saw it on TV that now wants it, and what does that look like? So that's where our clinical reasoning comes in, educating our patients on why we do it. Traditional cupping used to be left on the body for 15 or 20 minutes. And new research shows that leaving it on for 5 to 7 minutes has the highest effect of blood flow increases in the local area compared to 10 or 15 or 20 minutes. So that's, again, new research that sheds a little light on, well, maybe the way we used to do it isn't the most efficient way out there. And then when you think about having 15 cups on somebody's back, I mean, we see this every NFL football camp, when they start going, like all these players will post up recovery day and they have 15 or 20 cups on their back. And I'm just like, this is not recovery. You're causing more stress to the body. So I think, the social media world is notorious for taking something and just like blowing it up into something that's more dramatic and more entertainment than it is actually science. So you're going to see a lot of BS out there for that. And we have a whole series every Wednesday on our Instagram page. It's What the Cup Wednesdays, because I'm like, what the hell are people doing out there with cups or with hammers and, all these different implements that they're using out there for. And, sometimes less is more in my world with all that.
Oh, absolutely. Well, and I think part of it goes back to, I think when we look at, okay, maybe there isn't a lot of research on this method and things like that, or good high quality research. Can we apply some of the research principles to our clinical decision making? Meaning, if we look at it, how do we select the right patient? Because if I'm going to design a study that is going to show the effectiveness of cupping, I want to, that's almost my null hypothesis, right? Yeah. It's that cupping is effective. And if I want to design it, I want to select the patients that will have the most positive outcome with cupping. Yeah. So in clinical practice, so if we're almost kind of doing a N01 study, how do I select that patient? What does that patient selection look like so that I can get the best benefit for the patient?
Yeah. So I think when it comes to your physical exam and screening through whether you're going to use manual therapy at all, you have to decide where's that location going to be the most effective that I want to use manual therapy with. And so I use, again, I come from a movement screening background of, strength conditioning and NASM way back when. And there's no right way of moving. We're getting further away from the, right and wrong, but more into like, where are their patterns? Where do they tend to hinge? Do they have rib flare when they're doing the overhead squat? What does that look like when they're kind of moving through a pattern of, single leg squat or, lunging, and kind of where are their compensation components that we can have some effect on? And so when I see someone with a rib flare when they're doing an overhead squat or something, I go through and I'm like, I definitely want to palpate through that thoracolumbar junction and see, are those muscles, very tight and have tension? Is there thickening? And the term we like to use when it comes to connective tissue is this new term called densification. It's a much better term than using this idea of breaking up fascia or breaking up adhesions. And adhesions, again, I think manual therapists in the 90s took that term from laparoscopic surgery and ran with it. And they're like, oh, that's what we're doing. We're trying to break up adhesions. And adhesions are protein synthesis bonds, connecting pieces that you would need a scalpel to actually cut through. So you can't break up adhesions with the manual therapy. So when I'm looking at someone move, I'm like, okay, they're elevating their scap a lot when they're doing this low row, and maybe they love using that scapular elevation pattern. So I'm going to palpate through the upper trapezius and maybe levator scap. And then when I watch them do some rowing things, I also see a bit of hinging in their lumbar and their lower thoracic spine. So that's going to give me a clue into like, okay, I want to definitely put my hands on some of these areas, feel right to left, whether there's some difference in the tissue texture quality, whether it elicits any pain provocation or those types of things. So you can kind of feel for when tissues are thicker, right? When something is harder. A lot of my runners, I treat a lot of endurance athletes. They have one side TFL that's just like a hard rock. And it's generally the same side that they have their patellofemoral pain in or their patellar tendinopathy. And so when I see some of these patterns with it, I want to trace and make sure that my hands are touching some of these tissues that they feel are stuck, right? Because they come in complaining of, I can't feel my glutes. I have glute amnesia, which is, the silly term. But it's this inhibition of like dominant patterns. And so I want to palpate things like TFL on a runner when I'm looking at them go through a squat or go through a lunge pattern or test something like Thomas test. So we can use some of our flexibility tests, whether it's in Ober's or a Thomas or a prone Eli's test. So we're going to use some of those cues to kind of guide our treatment strategies by knowing where we want to palpate for densification. So that's from an algorithmic standpoint, how I know, like, might want to put a cup on somebody's TFL that's a runner when they're really dominant in using that muscle for some of their patterning that they're doing.
It kind of goes back to even the when we come to the foundational research is, does cupping with movement improve dorsiflexion range of motion compared to not doing it? Well, it appears that the answer to that question is yes, it does. So you could almost say that by systematically identifying the impairment that we're trying to improve, then we use, back to manual therapy, we use a test, retest model, a comparable sign, to say, okay, my intervention has had this effect. So it is really about identifying that target, because maybe that could be part of the problem that we're seeing in, the Instagram world of, we've got a dozen cups on someone. Well, what is the target? Like, what are we trying to improve? What, are we trying to improve their ability to touch their toes or deadlift or ankle dorsiflexion range of motion? And are those cups in the right place to indeed do that? And maybe they are, but I kind of have a little suspicion of that.
Yeah. And the nice thing is, you're right. You have to pick, validated tests that have been proven to be reliable, and then use those tests as a before and after intervention. The beauty of some of these manual therapy things, though, is that we're getting away from the specificity and the need to be so perfect in our desired location and, treatment effect that we're looking for, because there's a global systemic effect when we talk about the neurophysiology. So you don't have to be that perfect, especially if you're going to use low pressure, because, we talk about why higher pressure is great for getting down into the depths of an old scar tissue of a deep hamstring that got pulled. But you don't need that if you're just trying to provide some awareness to an area for movement strategies on something that they don't move very well. Maybe they don't understand how to go into hip extension, and that's why they don't feel their glutes. So maybe I'll put 1 or 2 cups on the anterior thigh and tell them to separate those spaces and feel a stretch effect so they get a bigger range of motion going backwards, right? And you don't have to be that specific on where you put a cup for something like that. So you have these global effects that make it's less pressure on you to be so perfect when it comes to identifying the exact location where you need to put that cup. Because a lot of this treatment is also that neurophysiologic effect that you're having downstream with it. Now, if you're trying to help scar tissue from an old hamstring thing like we were talking about, well, you're probably going to have to find that and feel which layer it's in, right? So is it in the deep fascia or is it in the intermuscular fascia? And understand, what the anatomy is in that area and then decide, am I going to use a small cup or a big cup? And am I going to use high pressure or low pressure? And we talk all about these parameters and how to be really effective through that treatment algorithm and some of the courses that we've done with MedBridge now.
So, really what you're saying there is specificity in the impairment measure that we're trying to improve or the outcome that we're trying to improve. Specificity is important there, but specificity of location may not be. And you could point to a lot of different, interventions, whether it is taping or manual therapy or a massage or trigger point release or are we really doing anything to the tissue? Maybe, maybe not, but we are certainly having a neurophysiologic effect, and that neurological effect, if we see an outcome change, that's our best hope for maybe identifying that we are achieving the outcome that we want.
Absolutely. I think that's why the water is so muddied when it comes to the cupping literature, is because in acupuncture, in traditional holistic medicine, there are very specific points. And if you don't hit that point, you're not going to have that desired effect that you're looking for. And new research, especially on some of the dry needling or some of the acupuncture needling, is you don't have to be as specific to these points as we used to think you had to. So there's these new studies about TMJ, and there's acupuncture points, and they did acupuncture points and then sham points, and they had exactly the same outcomes. So it just kind of shows us that the specificity of manual therapy techniques we used to think were so important 20 years ago when I first started learning them. Like, we had to be so specific, and then you can kind of see it, because if you did the wrong technique after going through a course that weekend, you're like, crap, I just messed it all up. But they got a great outcome anyways. You're like, why did that work then?
Right.
So
Absolutely.
It's just some of the specificity that we got a little too caught up on, and, understand the human being is a complex animal.
That's so true. So this has been a great discussion about where the research is, some clinical application. Can you take us through some case studies of how we would actually use this in our practice, whether it's in the athletic training room or in clinical practice?
Yeah, let's start with something simple. Because again, we've been talking about sports and we've been talking about some of this other high level movers. Let's talk about someone that just has scoliosis, right? You have a 14-year-old and she's coming in for idiopathic scoliosis, some back pain, and her parents are very concerned. They don't want her to go on to have surgery. And you find that, there's just poor body awareness of what that body position looks like. And we're going to use sometimes a cup to draw awareness to what those concave versus convex regions are in the spine, just to give a little bit more postural awareness before going on and loading those tissues. So if I have somebody that has a thoracic concavity, I would put a cup here on this part of the concavity and this part down here. And for those of you listening and not seeing, it's the top of the concavity and the bottom of the concavity, and say, all right, feel those two cups. I want you to stretch those apart. And now you have this kinesthetic tool on the body that gives them a better awareness, because they don't see their back. They don't understand what that looks like. And so for someone that has poor postural awareness and poor proprioceptive abilities, sometimes just drawing that awareness into that area with opening up that concavity with two cups on the body would be something that would be helpful.
That's awesome. So what about another case scenario? Like, okay, so that's good. So we're going from, we're using it from an input perspective. We're trying to change the input that the person's receiving so we can get a better output. What are other ways?
Yeah. So let's talk about, it's March Madness. You have basketball players doing their thing. And let's say you have someone that landed with an inversion sprain. It's a grade 1 inversion sprain. They've had a couple in the past. They're got a little bit of swelling. They need to play their next game in like 5 days. and they really have a lot of pain. There's some swelling in there, and there's some muscular guarding that's preventing them from pushing off, from having as good a Y balance, or star excursion. They're not able to support their leg and move the way they want to. So what we could start doing early on within the first 24 or 48 hours is use a cup on a lighter pressure to mobilize some of that fluid. And think about the lymphedema aspect of things. Like if you have swelling in that area and you want to push some of those fluids out, you can use a cup to kind of drag and effleurage some of that stuff. So that's an easy low-hanging fruit when we think about using a cup that way for mobilizing tissue. But then we can also think about some of these other muscles around there that are guarded and, on tension. So maybe their medial gastroc and their medial soleus and posterior tib are just on fire. It's just locked up because they, again, are going through an inversion sprain. They're overstretching the lateral side. They're compressing that medial side. And some of those tissues are generating pain because of it. So we can use cups on the inside part of their leg and have them go through some of those exercises for eversion to strengthen those fibularis or peroneal muscles on the outside part of their leg, while the cup is on that medial component of the leg. So you're getting a two for one. You're starting their strength things, you're starting to decrease pain, and you're getting some tissue glide on muscular tension areas that are sustained because of this ankle sprain that they've had. So that's something that's, you can use in that early acute or subacute phase as well. But then when we think about chronic things like chronic hamstring, maybe the hamstring has a high hamstring tendinopathy along with that, and we want to start loading them. So maybe this runner came in and they have a high hamstring tendinopathy. They've had this for 6 months or a year. We start putting cups on their hamstring while they go through something like a Romanian deadlift. So they grab the bar, it's just that 45-pound bar, and they're going to do slow, maybe some eccentric, more importantly, the isometric range of that particular movement pattern. And they have the cup on that high hamstring and maybe on the muscle belly while they're going through that to glide some of those tissues, again, decrease some of that pain intensity and improve their loading response. So there's three simple little areas where you can think about different pressures, applying different, layers of tissues that you're looking at.
That's awesome. One of the areas that you mentioned that is a big passion area of mine is recovery and the use of different modalities for recovery. You talked about, maybe putting 8 cups on somebody isn't recovery. Is there any application of cupping for recovery that would say, okay, I've got, one of the things we have to think about recovery is if I've put a stimulus in, we actually want to let the body recover because that's how it hypertrophies and that type of thing. We actually don't want to blunt recovery. It's a kind of a misnomer now. Right. But with that said, there are some times where you mentioned basketball. If I've got 2 basketball games on a Saturday and 2 on a Sunday, is there a place for cupping for recovery in that scenario after the first 2 games on there? Or is it you're like, no, it pretty well is designed to put a load on there?
Yeah, I think it's going to come back down to the same as your Normatec recovery boots and some of these other things. It's going to be a sensation of recovery more so than a physiologic change. If you looked at markers of IGF-6 and some of the other, inflammatory markers that you'd see before and after, you're likely going to see no big differences, just like recovery boots, just like some of the other recovery things out there. Now, the difference, that you can see when you're thinking about cup with effleurage and, again, lymphatics, if you try to mobilize fluids, maybe they have a small amount of swelling because it's an old chronic, issue with their ankle or issue with their leg. Some of those tissue mobility techniques, they have mechanical effects. You're moving around fluids. So you're going to change some of that viscoelasticity. You're going to change some of that densification when you talk about some of that. But yeah, I think when you're measuring markers and you look at the before and after, it's like ice baths. It's like Normatec recovery boots. You're not going to see a lot of physiologic change. It's going to be more changing their mental game and their mental preparedness for coming back the next day or coming back for that next event.
Awesome. All right. Well, so let's go to maximum impact here. What are our 3 actionable takeaways that people can walk away from hearing this episode and say, all right, I've got something I can use here?
Yeah, I think number 1 is you don't need to use 10 cups or 20 cups or, use less cups, use 1 cup, and I think when you think about the pressures you're generating, think about less is more. If you just want to change the way they feel, you don't need very much pressure at all. You're thinking about 100 to 200 millimeters of mercury. It's not very much. There's a lot of different units out there that have mechanical, plugins as well as handheld gauges that will show you the millimeters of mercury. I think the old cupping devices that are just pumps or the even older glass fire cupping, you just don't know what you're getting when it comes to the pressures there. So I think, first of all, less is more, and then making sure that you're trying to find some objective way of knowing what your pressure is, right? And if you want to get deep, you have to use higher pressures, like those 250 to 300 millimeters of mercury or more. But again, it's going to be anatomy dependent. In the neck, it's much thinner tissue than it is on something like the plantar fascia. So you got to be very specific to some of the anatomy with that. I think the second thing is always think about the cup as not a passive manual therapy tool. It's an active tool. You're going to put it on them while they're doing active, postural movement, changes or loading capacity. You're going to get them to have a little bit less pain as they go through that, tendinopathy loading, whether it's a leg press or an RDL or whatever it is. Put a cup on it on the first set and try to wean them off the cup for the second or third or fourth set, and their load capacity will go up. So I think that's a really empowering way of thinking about using a cup. And then just thinking about, trying not to get the client or the athlete addicted to this intervention, right? This is an adjunct intervention. It's something to be used and eventually weaned off. So you want to make sure you're constantly trying to use as little of it as possible and try to get them in terms of loading, looking at that loading capacity and getting them more movement and power.
Oh, that's fantastic. Well, awesome. This has been absolutely an enlightening episode here. And so as we wrap things up, can you tell us what things you're currently working on?
Yeah, so our newest study, actually, it's really fun. We put people in the MRI to see, can you palpate the psoas major? So both manual palpation as well as there's a tool called the PsoRite. I don't know if you've seen some of those psoas release tools, whether it's the hip hook or the PsoRite. But we want to see, can that manual palpation or that tool contact or get approximate to the psoas major structure, which is something a lot of people have learned over the years, that you have to, release your psoas to get your back pain better or get your hip pain better. Again, we're not trying to release things. We're just trying to relax tissues. But can you actually get close enough to palpate that tissue and distort it a little bit, right? To change some of the sensation in that area. And so that's our newest study. And we're going to present that at a Fascial Congress in August. Really interesting stuff. We got within 5 to 9 millimeters of the psoas major, which is, just the skin and the fatty layers with a little bit of muscle there as far as, the impedance to touching that muscle or getting close to that muscle. So really interesting things. It's been a debate out there for a while. Can you actually touch it past the organs, all the, peritoneal cavity? And so we found that you can, and it's pretty interesting how deep that actually goes.
That's awesome. That's fantastic. Well, very cool. This has been a great conversation. How can people connect with you?
Yeah, lots of ways. So we have our Instagram is probably our biggest platform, and it's just Cup Therapy. And our other Instagram is The Strength Therapist. We teach some courses on blood flow restriction and concussion management and running mechanics and running injury management. So that's all on those two different handles, The Strength Therapist and Cup Therapy. We have a podcast as well called What the Cup. You can check us out on there and lots of different really interesting science-minded individuals. And I think if you're really interested in fascia, there's a Fascial Congress this summer in New Orleans. That's a fun place to check it out. Just go check out Fascia Research Society.
Oh, that's awesome. Fantastic. What great ways to connect with you. If you'd like to connect with me, you can find me at philplisky.com, what I'm working on, other information, what I'm learning, I love to share. So you can connect with me there. This has been such a great time, Chris. Thank you so much for coming.
Thanks for having me. Thank you, MedBridge. Fun courses out there. Check out the MedBridge courses as well, of course.
Fantastic. Well, until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.